Thank you, everybody, for attending tonight. I'm very grateful that you've given up your evenings for this. As Sue has said, we'll be going through some of the rationale behind the program and how this is going to play out once this commences on July 1st. So I guess the first question a lot of people ask is, well, why are we screening for lung cancer? And the reason is it's such a common cancer. It's the fifth most common cancer across Australia. And as we'll see in subsequent slides, this is particularly prevalent in vulnerable populations, including Aboriginal and Torres Strait Islander peoples. It is the leading cause of death from cancer in Australia for both men and women, and is accounting for over 8,500 lung cancer deaths per year in Australia. When we look at some of the data, we can see that even though it is not the most common cancer, it is by far the most lethal. And when we look at some of the risk factors for poor prognosis after a diagnosis of lung cancer, we can see that how regional and remote you live is associated with a poorer outcome. That's on the bottom left of the screen here. And also with a decreasing socioeconomic status, your outcomes after lung cancer diagnosis also worsen. So we've known for a very long time that there are high-risk populations around Australia. This is another slide which unfortunately just again highlights, how many patients are being diagnosed with lung cancer every year, and the number is significant. If we focus just for a moment on one of the population groups which is most at risk, the Aboriginal and Torres Strait Islander people, lung cancer is both the most frequent lung cancer diagnosed and the leading cause of death. And we can see the darker columns represent the incidence on the left and the mortality on the right of lung cancer. When we compare the length of those columns to the lighter blue teal color for non-Indigenous matched controls, we can see that the Indigenous population has both a markedly increased incidence and mortality from lung cancer. Now, these principles of equal access to try to bridge the gap between these high risk population groups really underpins all the work that's been done in the last 2 years to develop this program. As well as that, we know that the number of lung cancer cases continues to rise year on year. We estimate, that by 2031, we're going to have nearly 16,500 people in that year diagnosed with lung cancer. That's a 17% increase over a decade. Partly this is because we have an aging population, but also we understand that there are multiple risk factors which may only now be starting to come to light, including occupational and other exposure risk factors. So why do we screen for lung cancer? What is the benefit of screening? Well, we need to know that a screening program will have the ability to impact the patient outcomes if we detect the disease earlier. It's one of the key principles of a viable screening program. We know that compared to other cancers, for example, breast, colorectal, prostate, and melanoma, as shown here on this slide, that the proportion of lung cancer diagnosed patients presenting in stage 4 is really high. It's over 40%. Compare that to breast cancer, which is less than 5% of women diagnosed with breast cancer present at stage 4. So we're trying to shift the dial back from a late stage diagnosis to an earlier stage diagnosis. And why is this an important impact on outcome? Well, if we look at the table on the right of the screen here, we can see that even though the proportion of patients who are diagnosed in stage 1, which is the dark blue bar, is low, the 5-year survival rate is really very high. Now, this data is a little bit out of date, and of course, with increasing treatment options such as immunotherapy and radiotherapy, we have more options to improve those survival rates. But if we just look at the way that between stage 1, 2, 3, and 4, the 5-year survival continually drops, we can see that by diagnosing people at an earlier stage, we strongly anticipate better outcomes and survival rates. So that's great, but how are we going to screen? Now, there's been lots of evidence for over 10 years now that screening with a CT scan in people who we know are high risk of developing lung cancer is associated with significant mortality benefit. This is a meta-analysis which was published by a group here in Australia a couple of years ago, which shows that there's a significant survival benefit across multiple studies generated often from multi-center trials from multiple countries, including data that came out of Australia. The seminal paper that came out initially was the National Lung Cancer Screening Trial from the US, which included high-risk patients who had a high smoking history. And these patients were screened for lung cancer either with a chest X-ray or with a low-dose CT scan. Now, the chest X-ray didn't result in any significant survival benefits. However, CT screening did result in a 20% lower mortality rate from lung cancer compared to those screened with a chest X-ray. So this really was the first really large-scale study which demonstrated a survival benefit for lung cancer screening with CT. This was followed up, as you would expect, with multiple other studies from around the world, including the Nelson trial, which came out from the Netherlands and Belgium. And this has now received more than 10 years of follow-up and again shows significant improvement in screening. So compared to participants who did not undergo any form of radiology screening, 24% reduction in mortality for males and 33% for females compared to the control group. So this and many other studies have now demonstrated the benefits in screening people with a high smoking history for lung cancer is associated with improved outcomes. So with all of this evidence on board, about 2 years ago, we were informed from the Department of Health and Aged Care that we would be having a national lung cancer screening program in Australia. And this is something that we have campaigned for many years, and it is testament to the very hard work from many people and many different organizations that we're at the point we're at now. The goals of the upcoming program are really very simple and can be summarized into 3 dot points there. We want to reduce the number of people dying from lung cancer in Australia. We want to enable access to people who are currently smoking to try to stop smoking. So smoking cessation is a constant theme throughout the program. And we want to make sure that the vulnerable patients that we know are most at risk, including those who are Indigenous or live in regional or remote areas, have access to the program. And in order to do this, there will be an MBS-funded low-dose CT provided for eligible patients who decide to participate in the program to enable earlier stage diagnosis of lung cancer. And this program starts on the 1st of July this year, which is in about 6 weeks' time. Now, we have been preparing for this for well over 2 years, and so what you're seeing today is the culmination of many people's hard work over that time. This is a summary, a very high-level summary about what will happen to get a participant into the program. The person will go and see their doctor or their other healthcare provider and be screened for eligibility. This person can decide to self-select and say, hey, I'd like to participate. Am I eligible? Or it may be an opportunistic conversation when they come for some other reason. Once the person has participated or agreed to participate, there's a few steps that you'll need to do, but one of those is referring that person for a CT scan. They can then come along to a radiology clinic, which is participating in the program, have their scan, and a radiologist like me or Janu will read the study and deliver a report. Depending on what that report says, there'll be a number of different outcomes, which we'll go through a bit later today. And then if everything is clear and there's no need to do anything sooner, that person will be asked to attend again in 2 years' time. So let's talk about the eligibility criteria, because this is a key question that we get all the time. In order to be eligible to participate in the program, you have to be between 50 and 70 years of age. You must have a tobacco smoking history of at least 30 pack years, and I'll briefly explain that in a moment. You can be an ex-smoker, but if you are, you must have quit within the last 10 years. You can't be symptomatic of lung cancer, and I'll explain what that means in the next slide. And If you are continuing to be within the 50 to 70 year age group, you'll be eligible to screen again in 2 years' time. You do not have to quit smoking in order to be part of the screening program. So that's a common question that we've received from many people who've found out about this program. And there's a wonderful resource guide for GPs, which has been published within the last couple of weeks on the Commonwealth Government website, which I've got the link on the bottom of the page there. It's a really well-written and easy to read document. So a little bit more detail about what you need to ask. And again, you'll get lots of information through alternative channels about that, so I won't dwell on this. But some of the symptoms and signs of lung cancer could be an unexplained persistent cough that hasn't been explained by another diagnosis. And I'll explain what some of those could be on the next slide. Hemoptysis or shortness of breath, which isn't going away and hasn't been explained. When we talk about the suitability for CT, there's really not many reasons that people can't have a low dose CT. We don't give intravenous contrast, so we don't really have any reason to ask about renal function, and certainly patients who are allergic to contrast can have this study because we don't give them any contrast at all. The really important point is probably the first dot point here. If your patient has had a CT scan in the last year, or they're about to have one in the next few months for other reasons, just think about whether or not they should come for the CT. Now, if they previously had a CT because they had an acute process like pneumonia, we wouldn't have been able to assess all of the lungs. And so that person will still be eligible to have their HR-CT study. But if they've recently had, within the last 3 months, a symptomatic lung infection, so forms of pneumonia, for example, you should probably wait until they're completely clear clinically before you refer them for the CT. Because if we can't assess all of the lungs due to that acute process, we'll just have to call them back. There are some people who are unable to lie flat for 5 minutes because that really is how long the scan takes. It's very quick. And we'll be asking them to hold their arms above their head for the CT. Depending on your local radiology provider, there may be an upper limit for weight, and if your patient exceeds that amount, they may not be eligible to have a locally performed CT. And I'm sure you'll be able to check that with your local provider. Now, what are the other diseases that people have, and how does this affect their eligibility? Well, lots of those, different pathologies written there on the left side of the screen will be present in patients who have been long-term smokers. Even if they have been diagnosed with these conditions before, they are still eligible to be screened for lung cancer. In fact, we know that in damaged and diseased lung, the risk of developing lung cancer is higher, and so we don't want to turn these people away. If any of these diseases have been diagnosed before, please write it down on the referral because it does help us immensely, particularly if there's a history of cancer. And in a few slides' time, I'll talk about what we need to write on the referral. But any particular cancer, particularly anything currently being treated, we absolutely must know because that will help us when we do our reporting. I just wanted to talk very briefly about pack years, and I'm sure there will be much more information given to you all about this. You don't need a radiologist to tell you about that. But it's just to highlight that it is a guesstimate for how much smoking someone has had cumulatively throughout their life. It is an estimate of how long and how often someone has smoked. It's really difficult if there's also been, pipe smoking, shisha, cigars, or if they roll their own cigarettes. It's very difficult to measure the amount of tobacco which has been inhaled. And so overall, the program is inclusive. If you're not quite sure if they just meet the 30 pack years or not, be inclusive and offer them eligibility to the program. That's the advice that we've been given. Now, how do you refer a patient through for the CT? How do you actually do this in practice? Well, once you have a participant who's agreed to be part of the program, you can make the referral for the low-dose CT scan. So check your local radiology providers because we know that not every radiology provider will be offering this service. This is a new type of reporting, which I'll run through in a moment. And not everyone's going to be able to offer this. And certainly not everybody will have a CT scanner, which is able to provide low dose imaging. Obviously, we've worked very hard at IMED for many years to make sure that we can offer this. And so all of our clinics with CT scanners will be offering the program. And we continually monitor all of our radiation doses in all of our CT scanners using a program called DOSE, which is unique in Australia. Now, what do you need to put on the referral form? And this is a really important point because the program has produced an official referral form, and you'll be able to see that when it's released officially in the coming days and weeks. But you are very welcome to use your own forms, and this includes electronic referring, because if you're already accustomed to electronic referrals, why would you want to go back to using pen and paper? It doesn't make sense. So the information that you need to put on the referral, I've put here on the screen. I've put in bold with underline the most important point. If this is a referral into the National Lung Cancer Screening Program, absolutely, please, you have to put this on the form, because otherwise, if you write CT chest and you don't mention that it's for lung cancer screening, we won't know how that is the protocol and that is the type of report that's required. There are two other pieces of information that are really important for us. The first one is whether there is a family history of lung cancer. And the reason for that is it's becoming incorporated into our malignancy prediction tool. And this means parents, siblings, and children of the participant. And the other really important piece that we really struggle with sometimes is knowing whether that person, that participant, has a personal history of cancer. So please write that down as well, because that will obviously help us interpret lung nodules if we see them. So IMED has also produced its own paper form, and that's what it looks like. It's very similar to the final program referral, and you can see that there are tick boxes. It's very easy to use. And if you would prefer to use this type of form, please let your local account manager know, and we'll be able to make sure that you have these in time for the start of the program. But these are the important points that you need to include. And obviously, there will be a lot of other clinical information which could be relevant as well, including some of those other diseases like the emphysema, the fibrosis, and the sarcoidosis, just to mention a few. So there are a couple of other quirks about this program. I know that many GPs around the country are very familiar with the NCSR because they already run the database for cervical and bowel cancer screening programs in Australia. The NCSR will also be running the central database through a portal for the lung cancer screening program. As part of this program, the NCSR will send communications to the participants as a reminder for when action is required, either to come back for another scan or to go back to see their referring doctor. What's new for us in the radiology sector is that we must upload our reports to the register, which sounds very straightforward, but it's a very complicated template report, and the sector is currently going through a lot of work to be able to do this. We will, of course, continue to send the report back out to you as the referring doctor. And the web link at the bottom of the page is, for general healthcare providers, if you're not familiar with the NCSR, this is a very helpful page. So let's talk about what happens in the actual CT part. It's very straightforward. I'm sure many of us have had CTs before. It's a very quick scan. It's non-contrast. It's bulk billed, so the patient will not be out of pocket when they come for the CT study. As I've said, we need to know from the referral that the patient is part of the program, because that confirms the eligibility for us. There is a different Medicare rebate, and it's a slightly different acquisition protocol. We will provide a structured report, which everybody must use no matter where they do their reporting. And every one of the nodules that we find in the lungs that is eligible gets critiqued, and up to 4 nodules are reported on every study. Once we've done that report, we send it back to the register, and we send the report back to you. Which brings me to, how do you interpret what we send back in the report? Because it will look very different to a regular CT chest report. Every nodule that we see, we look at and we say, is this something which is reportable? And we analyze it for its risk of malignancy. And depending on how high that risk of malignancy is, we give it a category. And the categories for each nodule go from 1 through to 6. I'll say now that category 0, if you get that back, it means that something acute's happening. So perhaps there's pulmonary edema, or there's, pneumonia affecting the assessment of one or more parts of the lung. That means it's an incomplete study, and we're going to give a recommendation as to when that person should come back and have another CT to complete their screening. So provided it's not a category 0 result, you'll get a 1, 2, 3, 4, 5, or 6. And that gives an overall assessment of how likely that person is to have lung cancer. I'm going to run through what that means. For the baseline study, which is the first study as part of the program, in patients who don't have a previous CT chest to compare it to, we're using a modified version of what we call the Pan-Canadian or PanCan model that came out of Brock University. This has been around for about 15 years now, and it's a way of measuring the malignant potential of an individual lung nodule. We require a certain amount of information, including the patient's age and their sex, whether or not they have emphysema visible to us on the CT scan. We need to know about their family history of lung cancer, which is why we need you to write this on the referral. When it comes to individual nodules, we measure the size of them, we measure the density, we talk about, is it a smooth nodule or an irregular nodule? You can leave all of that up to us as the radiologist. What we do is we produce a percentage risk that that nodule is lung cancer. And that percentage forms the basis for most of the nodules we're going to see on baseline scanning. As you can see, each of these categories, whether it's very low risk or category 1, all the way through to very high risk, category 6, increases in terms of the PanCan risk. So if you have a nodule that has less than 1.5% chance of being lung cancer, and that's the worst that we see on the scan, you'll end up with an overall scan result of category 1. And so on, 1.5 to 6% is called low risk or category 2. 6 to 10% low to moderate risk is category 3. 10 to 30% risk that a nodule is cancer is moderate risk, category 4. And above 30% is considered high risk, category 5. Very high risk, category 6, is what we call the radiologist category. If we see abnormalities that maybe aren't just related to a particular nodule, but other things on the CT that make us think that this is lung cancer, we can bump it up to category 6 for the overall study. For example, if we see metastatic disease or we see lots of enlarged nodes in the chest. So what does that mean in terms of patient follow-up? Well, if it's not a category 0 study, we look at the nodules that we've reported in the scan and we say, well, the highest category of those nodules becomes the highest category for the study. If you have a very low risk 24-month recommendation, that means it was category 1. All the way through to, category 5 and 6, which means don't wait, refer this person now to a respiratory physician that's linked to a multidisciplinary team that deals in lung cancer. And that will vary depending on where you are and what your local referring patterns are for specialists. Obviously, we have a lot of people that will come back in 2 years, which is great. And we think that that will be the majority. But there will be some people who give a recommendation to say, we want to see you in 12 months instead of 24, or maybe in 6 months, or maybe in 3 months. And this relates to how urgent we think it is to get some follow-up. This will be spelled out very clearly in the report, particularly in the final recommendation section. So that's the baseline study when your patient comes to us for the first time as part of the lung cancer screening. Obviously, we would anticipate and hope that they come back for further imaging, whether it's in 2 years if their initial study was clear, or whether they come back at 12, 6, or 3 months for an interval follow-up study. Now, these follow-up studies are, from the radiologist's perspective, more complicated. From the patient experience, however, it's very similar. It's a non-contrast study, again done in exactly the same way. It's very, very quick. They do need a referral to come back, so you will need to write another referral for them. From the radiologist's perspective, we use the same concept of categories, with a category 0 being an incomplete study, all the way through to category 6. But now that we have a time interval between the first study and the subsequent study, we have more information about how a particular lung nodule is traveling over time. This can be reassuring if there is stability or, in fact, improvement in appearances over time. And of course, it could be concerning if appearances have worsened. So if the nodule has gotten bigger or is now showing more high-risk features. And so we use this stepping down approach if things become reassuring, or stepping up if the appearances progress. This is a more complicated approach for us as the radiologists. And again, you don't need to really worry so much about how we generate this, but there's a lot of information that we will need to go through when we write these reports. What we say at the end of it, though, is similar. We give an overall category for the study that is 0, 1, 2, 3, 4, 5, or 6. And along with that, you have exactly the same recommendation for interval. So a category 1 study, whether it's a baseline study or a follow-up study, we recommend a 24-month interval before the next scan. Similarly, for a category 2 study, we recommend, as it's low risk, not very low risk, that we get them back in 12 months for another scan. And this information will go back not only to you, but also to the NCSR, which will be able to send reminders to the participant to come back at the appropriate time. This is a really bespoke approach to how we manage lung cancer screening. And it's really trying to see how we can best use the resources that we have to make sure that patients who are most in need of follow-up have access to the scans when they need them. Whereas people who don't have any signs whatsoever of lung cancer in that very low risk category can go away and know that and be reassured that 2 years is a safe time to come back. There's been extensive work done on this based on evidence from around the world, including on research trials done here in Australia. And the work here really must go to the ANZ-STR in collaboration with the Thoracic Society of Australia and New Zealand. And both of those organisations have put in an absolute mammoth effort to get through to these baseline and follow-up nodule management protocols. So please bear with us when we're starting to report these, because this is going to be new. And I'll run through at the end about how IMED is approaching how we're going to do this. But I would like to hand over to my colleague, Dr. Janu Pirakalathanan, and she's going to talk now about a different part of the screening program, and that is, what do we do with the additional findings that we see on a CT scan? Thank you, Janu.
Thanks, Catherine. So I will be talking about the additional findings and how this is going to be reported, and also the recommendations. I noticed that on the chat there was a question regarding this, and the next few slides will address that question. So if we move on to the subsequent slide, because we are imaging quite a large proportion of the body, the thoracic region, including parts of the lower neck and parts of the upper abdomen, we do anticipate that there will be some incidental findings in these CTs. We estimate that about 10% of the cases will contain at least one noteworthy finding. So with regards to this, the most important thing that you guys will need to keep in mind is that simple lesions that are considered benign or have little clinical consequence to the patient will be unlikely to be reported on the scans. So if we see a simple renal cyst or a simple liver cyst, the idea is not to report these as they will not have much clinical consequence to the patient. However, if we do come across findings that we consider are relevant to the patient, either immediately or for their long-term health, then these will be considered actionable findings, and then appropriate recommendations will also be noted in the report. So it's not just that we notice the findings, but we will then be making additional recommendations as to how to either further investigate or follow up these findings. Now, these recommendations have not just come about through the lung cancer screening program or through the College of Radiologists, but it has been extensively developed in collaboration with multiple societies, including your own, the Society of the General Practice, the College of General Practitioners, as well as the Society of Cardiology and Thoracic Imaging, and the the Thoracic Society, as well as the surgical societies. So on the subsequent slide, and just to reiterate my previous point, findings that we think are unlikely to be of clinical benefit for the patient and will only contribute to the anxiety of the patient and potentially result in further investigations that are unlikely to have any long-term effect on the patient's health, such as simple thyroid nodules, liver cysts, a small amount of pericardial fluid, will not be reported on the scans. However, we will be focusing our attention on findings that we think are relevant to either the patient's immediate health or their long-term health. So examples are coronary artery calcification, calcification of the aortic valve, and interstitial abnormalities, which may suggest that the patient is developing pulmonary fibrosis. Now, the next 4 slides are quite detail-oriented, and I'm not going to go through it line by line, but it's to say that through this process, we have considered a number of abnormalities that could be seen on a low-dose non-contrast CT. So examples are emphysema. On the next page, you can see there's interstitial lung disease, bronchiectasis, cystic changes, nodular changes of the lung, pleural abnormalities, mediastinal abnormalities, and a whole host of vascular and thoracic abnormalities. And that these will either be reported, and you can see here, for example, pericardial effusion, small effusion will not be reported, moderate to large effusions will be reported, and then the appropriate recommendations and how those recommendations came about in terms of through collaboration and consultation, as well as review of previous literature. So at the end of the day, the recommendations are purely recommendations. They're at your discretion, and ultimately it will be up to you whether you act upon these recommendations or not. And as Catherine was alluding to before, because you are aware of the patient's entire history, you may be already aware that the patient is being managed for an underlying lung condition. They're already being managed for another malignancy. They have known coronary artery disease that is being effectively treated or managed either by yourself or by a cardiologist. Then these recommendations that we make in the report may not need to be acted upon. But it's purely to highlight that these findings were evident, and if the patient hasn't already had investigations or management for these findings, then you can institute that at that particular time. But ultimately, it'll be up to you whether you choose to act on these or not. So the next slide, I'm going to focus on one particular one that I think is more likely to come up in this cohort than in any of the other general population, and that is calcification in the coronary arteries. So just to be clear, calcification in the coronary arteries is related to atherosclerotic plaque. You don't get benign calcification. And for this very reason, this is something that is going to be more likely reported in this particular cohort. It increases the risk factors for cardiovascular events, cardiovascular-related mortality, and all-cause mortality as well, and is often underreported on most CT scans. And if we look specifically at the lung cancer cohort, you'll notice that these people have been previous smokers. And as a result, that is one of the risk factors for developing atherosclerotic disease. So these patients, I think, are going to have a higher prevalence of having calcification in their coronary vessels. Now, how does the radiologist look at this and report it? So it will be a visual interpretation of the degree of calcification. It will not be quantified. And essentially, we're going to have a look at the vessels to decide whether there are a few flecks of calcium or extensive, contiguous, dense calcified vessels. And based on how the scans look, we will then be reporting them as either mild, moderate, or severe, keeping in mind that this is a visual inspection of the vessels. And based on those severity of the calcium, we would suggest either consideration of lifestyle modification, potentially instituting pharmacological therapy and further evaluation as you guys see fit. And it will also come down to either whether the patient is symptomatic or asymptomatic at the time that they present, and whether they have any other relevant risk factors that will need to be acted upon. So I think that's the last for my slide, and I'll hand it back to Catherine to complete this. And then there's a few questions in the chat that I can see as well.
Thanks very much, Janu. That was a whistle-stop tour through additional findings. As we've said, there's a lot more information available for the radiologists and for the referrers on the National Lung Cancer Screening webpage. I just wanted to finish off by, I guess, explaining how we have taken the approach to the lung cancer screening program here at IMED. IMED's the biggest radiology provider across Australia, and so we feel like we have a significant obligation to make sure that we provide a high-quality service in this space to all of our patients, whether they be in the cities or in the regional areas. Now, none of these are considered to be urgent cases. The Department of Health and Aged Care has suggested that a 14-day turnaround for the report would be acceptable. We've committed to do a 3 business days to report turnaround, and you may get it back much quicker than that. We will be starting off the program with a dedicated team of chest radiologists like myself and Janu, who've been involved in developing the program. So not just developing the approach from IMED, but developing the program design itself. We have other radiologists from across our reporting network who are joining our team, who've also undergone extensive training and upskilling in exactly how to do this type of reporting. We have been running a number of workshops around the country that I've been running and that Janu's been helping me with, and we're only taking people who've done the full upskilling and training. We will be mentoring and guiding radiologists who join our reporting team over the first 3 to 6 months to make sure that there's always an opportunity for a second opinion if there's anything of concern. We just think that this is the most appropriate thing to do, given that this is a very new type of reporting of a CT chest study for everyone across Australia. And we're very lucky that we have such a collegiate group of doctors all willing to work together. But as I'm an AI person, of course, you couldn't do anything like this without AI tools. And so we're using state-of-the-art AI to assist not only with detecting the lung nodules, but measuring and characterizing them as well, which will make sure that the chances of missing something important are even lower. And like I said earlier in the presentation, all of our CT fleet, all 190 of them, I think, roughly, we monitor the radiation outputs for all of our CT scanners every single day. And we use a program called DOSE, D-O-S-E, and it means that we're able to flag anything as an outlier for radiation dose and to make sure that it is not something which is related to a technical or mechanical abnormality. And we've been able to accredit all of our CT scanners across the country for low-dose imaging in other screening programs, and we are well and truly ready to do low-dose CT chest as part of this program as well. So you may get a report back from myself or Janu or one of our colleagues who's not in your local team where you live. Don't be upset by this, please. This just means that we've sent this to our crack team of reporting radiologists who do this day in, day out. Now, I'm sure that there will be lots of questions, and I can see more and more questions appearing in the chat, which we'll get to in a moment. But just to leave you with this final slide, we have put together a page on our IMED page, which you can click to immediately with the QR code here. And there's lots of resources on that page for our referring doctors. There's also the QR code on the left bottom part of the screen, which will take you immediately to the Department of Health and Aged Care page, upon which you'll be able to see some of those GP dedicated resources, which I think will be very helpful for you if you haven't seen them already. Now, IMED has account managers in every region where we have imaging services. If you have any questions, please feel free to reach out to your account managers. They are all very much aware of this program coming. It is such an important public health initiative for this country. And you'll also be able to download that referral form, although you are able to download it, as Sue said, from your handouts tab on your page that you're using right now. So that was the end of the formal content. I know we have lots of questions, and so Laura, I might hand it over to you.
Thanks very much. And thank you both for that amazing presentation. Lots of questions to get through. Our first question of the evening is, what is the MBS item number and how much does it pay?
So that's a great question to start off with. It pays a tiny bit more than a regular CT chest, but not much more, given all of the amount of work that we have to do to put into this. And it pays about $320. I don't remember the two item numbers off the top of my head, but it's a separate item number for the very first baseline scan. And then every subsequent CT after that as part of the screening program is considered a follow-up or interval scan. And so knowing that that person is part of the National Lung Cancer Screening Program is vital to make sure that we build the right code.
Thanks very much. And I can see here that Dr. Pirakalathanan has just said that the item numbers are 56301 and 56302. For those that are interested. Our next question is, what assistance is being offered to general practices to identify and contact patients for this program?
So that's another great question, and probably not one that I, as a radiologist, can answer. However, your PHNs should be able to provide that information. And I know that there's information that's come out recently from the RACGP, and I believe also coming out shortly from ACRM exactly around this. I think from a common sense perspective that there will be variations in how each individual practice will approach identifying patients on their list that may be eligible.
Thank you. Now, you mentioned in the presentation lung cancer history. Do you mean only primary cancer, or does this include metastases as well?
Good question. So when it comes to the family history of lung cancer, which is to be written on the referral, it is lung cancer, so primary lung cancer. So if one of the participants' primary relatives, so either the parents, siblings, or children, had metastatic lung disease from another primary somewhere else in the body, that's not what we mean by a family history of lung cancer. We would love to see in that box that says, do you have any personal history of lung cancer? We'd love to see what that cancer was from. So it could be bowel cancer, kidney cancer, lots of different things. And if there has been lung mets in the past, that would be so useful for us to know.
We have a couple of questions around nodules. The first question is, what is the follow-up for no nodules? Is it also 2 years?
Yes. So no nodules automatically puts somebody into the very low risk category, and that's come back in 24 months.
Perfect, thank you. And there was another question around nodules. With a maximum of 4 nodules, what do we do if there are more nodules found?
So we put in the 4 nodules that have the highest associated categories. For example, if you had a category 5 nodule and then a 4 and a 2 and a 1 and a couple of other category 1 nodules, we'd put in the 4 that were the highest categories. There's a chance, and of course it will happen, that we might have 5 nodules and they're all category 3. It's up to the radiologist's discretion as to what we would put down in terms of our report. Ultimately, though, we put in 4 because if we start putting in 20 or 30 or 50 nodules, nobody's going to read our reports and none of us will ever want to do another report like that again. So the 4 nodules, which are considered to be the highest risk, It doesn't mean that we didn't see the others. It means that we saw them, we assessed them, and we assessed them as being lower risk of being lung cancer. All of the reports over time will be downloadable as well from the NCSR, and so you'll be able to see how different nodules track over time.
Perfect, thank you. A question around vaping. Is there an equivalent pack a year for this?
So vaping is not an eligibility criteria for this program, unfortunately. I've seen many examples of vaping-related lung injury, and I think it's a scourge that we're not going to be rid of for some time yet to come. But vaping is not considered to be an eligibility criteria.
Smoker's cough. If a patient has chronic smoker's cough, does that mean they can't participate in the program?
No, absolutely they can participate. If they've had chronic cough, which is stable and has been put down to probably bronchitis, that's absolutely fine. They should be included in the program, which is different to, a recent cough over, 1 to 2 months, which might be getting a bit worse, particularly if there's any other symptoms as well, then you would consider that to be a patient who's symptomatic. But very much so, chronic shortness of breath, chronic cough, chronic shortness of breath on exertion, unexplained respiratory tightness, all of those things, as long as they have been, put down to something else, they absolutely should be included.
And we have another question around eligibility. Does the program allow patients over 70, or does IMED allow patients over 70 if they understand that there's no Medicare rebate?
So that's a great question as well. So there won't be any rebate because they've now aged out. So the age is above the 70 years. Noting, actually, I should just say that it's not until you turn 71 that you become ineligible, which sounds like a nitpicking point, but actually you can be 70 and still have your scan. But if you're 71 or older and you as their, referring doctor believe that they would benefit from having a non-contrast CT to look through their lungs, absolutely we will scan because it's so low risk and the benefits are so high. There just won't be a Medicare rebate for that study.
And we had a question.
Oh, and sorry, one other thing,
yeah.
Laura. That person's report will not go off to the NCSR. The report will simply go back to you as the GP, and it may come back as a standard CT chest report style.
Great point.
Yeah.
We had a question around radiation dose. Do we know approximately how high the radiation dose is?
So currently, the recommendation for the acquisition protocol for this study is it has to be less than 3 millisieverts. We think that's actually still too high, and so we're doing 1 millisievert or less across all of our CT scanners. So even though the program itself is saying 3 millisieverts, we've taken the approach that we can do better than that across our fleet. Good question.
Thank you. We had a question around the imaging pathway. So if the scan shows metastatic lung cancer, querying a primary, does the GP organise a CT chest abdo-pelvis and refer appropriately, or do they refer to a chest physician?
I would say do whatever you would normally do in that situation outside of the screening program, because that person is now going to enter, an urgent referral. I would make the referral as soon as possible, and whatever your local respiratory team associated with the lung cancer MDT would like you to do is my advice to that. Inevitably, they will end up having a CT chest abdomen pelvis. They will most likely also have a PET CT, and if appropriate, they will also have a biopsy. And that can all of those things could be arranged through the respiratory team after they've seen the imaging. Just on the topic of what happens next, it will vary from region to region around the country. But rest assured that the respiratory physicians and all of the oncology teams working in centers that do lung cancer work are very, very focused on this to make sure that they are ready for additional referrals. And as well as that, radiologists like myself and Janu that work at hospitals and we do lung cancer work, we're going to be looking at a lot of these CTs to make sure that yes, there is something here that's worth a referral and biopsy, just as we would for every other patient that comes through the door.
I had another question around vaping. So if someone has a patient who has quit smoking, gone on to vaping, but ultimately quit smoking in the last 10 years, but they smoke cigarettes first, as long as they have quit in the last 10 years, are they still eligible?
As long as they've quit smoking the cigarettes or cigars or pipes or shisha, as long as that form of their tobacco inhalation was within the last 10 years, then they will be eligible for the program. If they've been vaping for more than 10 years, I'd be impressed because it hasn't really been around for that long. But that will become a problem as time goes on. Right now, unfortunately, vaping is not considered to be any part of the eligibility criteria.
And another question, will these results be recorded on the eHealth record?
So if you mean my health record, then the answer will be yes, because radiology practices will be uploading all of our patient information to my health record unless there's been a specific request by the participant not to. It's also possible for the participant to request that their information is not stored on the NCSR, but I think that's going to be a very low percentage of people, given that it's a very low percentage of people who opt out of their data being on the NCSR for the bowel cancer and cervical cancer screening programs. But it is still a possibility. It just means that their information won't be logged and they won't receive reminders.
Thanks very much. I might wrap up there. We did just have a couple of questions around the compatibility of the referrals in Best Practice Medical Director. IMED is working on this and we will make it available for you to use directly within your practice management software. We'll keep you updated on that. I wanted to again thank our presenters for the presentation this evening. If everyone can stay online, in the handouts tab, there's a link to the evaluation survey. Your feedback is really important to us, so if you could take a couple of minutes to fill that out. And I'd like to thank everybody for joining, and we'll see you next time.